Hello and a warm welcome to this annual Stephen Hawking MND lecture, and a special welcome to people from around the world, as I know lots of people are tuning in to this lecture tonight. You're very, very welcome. My name is Dr. Sean Pert and I am the chair of the Royal College of Speech and Language Therapists here in the UK, and I'm delighted to be hosting tonight's lecture. The lecture is a collaboration between the MND Association and the Royal College of Speech and Language Therapists and is generously supported by the Stephen Hawking Foundation. We'll now move to a pre-recorded message from Tanya Curry, CEO of the MND Association, and then we'll welcome our guest speaker, Professor B. Wee. Thank you so much. Over to you, Tanya.
Hi everyone, I'm Tanya Curry. I'm the Chief Executive of the Motor Neurone Disease Association, and I'm delighted to be here with you to introduce the 2023 annual Stephen Hawking MND lecture. This is a significant event for the association that's been running since 2017. This year, we're really pleased to be delivering this lecture in partnership with the Royal College of Speech and Language Therapists. I would also like to extend really grateful thanks to the Stephen Hawking Foundation for their financial support and their ongoing support of this event. The focus of tonight's lecture is on advanced care planning, a subject that's really close to my heart. As an ex-specialist nurse in palliative care and having come from the hospice sector, I really see the benefit of this care for people with motor neurone disease. Advanced care planning is a term that we use to describe the conversations about care between people, their families, their loved ones, and those that are looking after them. It's central to delivering effective health care for people living with motor neurone disease, and a disease that can progress so quickly. It's about future wishes and priorities for care needs, and is of course therefore relevant for the practice of every discipline looking after patients. Advanced care planning empowers patients, puts them in control of their care and the decisions that they make. It is a means to improve care for people nearing the end of their life. It supports practitioners and colleagues to better plan for the care of patients and their families. And it can really help people live with choice, with control, but equally it helps them die with dignity in the place and in the way that they choose. Effective advanced care planning underpins the best care possible. This stimulating and thought-provoking lecture will be given by Professor B. Wee. Professor Wee is an authority on the subject, having championed effective palliative care for many years, not least as National Clinical Director of Palliative and End-of-Life Care, NHS England, between 2013 and 2023. Tonight, she will outline the emergent thought in practice and research in this area and explore how all professionals can contribute to successful, meaningful planning with people living with MND and their families. I am certain you'll find this evening thought-provoking, valuable and motivating. So thank you very much for joining us, and I really hope you enjoy the lecture.
Questions from the audience, and you should be able to ask questions by accessing the Slido toolbar, which is to the right of your screen. If you can't see the Slido toolbar, then you may be watching in maximized view. You need to minimize in order to see that Slido sidebar. If you do ask questions though, please remember that if the information is sensitive or could identify a person or patient, to please make sure that that's anonymized or removed from your question. The lecture will be subtitled, and just a reminder to everyone that it will also be recorded. A CPD certificate will be available to download via the PDF link at the bottom of the digital player page. So now to introduce our guest speaker, Professor Biwi. Bee was National Clinical Director for Palliative and End-of-Life Care for NHS England from 2013 to 2023. She's a consultant in palliative medicine at Sobel House and Catherine House Hospice, Oxford University Hospitals NHS Foundation Trust, and Associate Professor at the University of Oxford, where she is also a Fellow of Harris Manchester College. Bee is also a Non-Executive Director of the National Institute for Health and Care Excellence. So without further ado, I'm delighted to hand over to you, Biwi. Thank you so much, and we're really looking forward to hearing what you've got to say to us. Thank you.
Thank you very much, Sean and Tanya, and everybody for giving up your time this evening. And thank you. I would like to start by thanking the Motor Neuron Disease Association and the Royal College for Speech and Language Therapy and the Stephen Hawking Foundation for inviting me to speak this evening. It's a privilege to deliver this lecture. Before we get started, however, I would like to have a sense of who I'm talking to, and therefore we're going to start with just a couple of questions. The first being just to understand who you are in the audience, given that I can't see all of you. So perhaps I could ask our technical support colleagues to put up the first question. Thank you. I think that's beginning to stabilize. So that's really helpful. Thank you, everybody. So we've got lots of allied health professional colleagues with us, which is brilliant. Fantastic to have you there with us and all the other members of the multidisciplinary team, academics, people with lived experience, right across the board, and our third sector colleagues. So thank you for that. May I move on to the next question, please? Because again, it would be great to have a sense of your experience with advanced care planning conversations. So could I ask you to respond to that? Okay, so it's pretty much across the board. Fantastic. Thank you for doing that. Right, I'm going to move on to my slides now, please. So this evening, we're going to talk about planning ahead. And as Tanya said earlier on, it's a process we often refer to as advanced care planning. And of course, it's not just about healthcare decisions, and it's not just about the dying phase, which I'll show you. But it isn't meaningful if it is too broad and if it doesn't have a context. So I've been in situations, I'm sure some of you have been in, where I'm in a big room and somebody says, hands up, you know, who has an advanced care plan? And actually, it doesn't mean anything if there isn't a context for it. So I'm going to go on to discuss that a little bit more. But let me start with reminding us of Dame Cecily Saunders, who I suspect I don't need to say much to most of you in this audience, but I think this really epitomizes what we mean by person-centered care. And this was a quote from her: "You matter because you are you, and you matter to the end of your life." And that is so powerful, I think, as a quote for us to hold on to. I am conscious that in the last 2 years, you've had talks from Idris Baker about person-centered care and Stephen Block about communication. And of course, everything they have said in those 2 lectures are really key to what I'm about to talk about this evening. But I am going to focus particularly on that future care planning. The ambitions framework, the ambitions framework has 6 ambitions. And again, I hope that this audience will be very familiar with the national ambitions for local action, which is ambitions for palliative and end-of-life care. We had 6 ambitions to bring about that vision about the one on the right, which is a person-centered statement about how I can make the last stage of my life as good as possible. And the first of those ambitions is about each person being seen as an individual. Of course, all the other ambitions are equally important, but just as one of the statements is about, as you can see, it couldn't be more person-centered. And that person-centeredness is not just about the person who's living with the illness, but also their caregivers and those who are important to them. So why isn't person-centered care a given? You would think that, that's it. It sounds like a bit of a no-brainer, doesn't it? And the Institute for Health Improvement says that as the system grows more complex and more fragmented, and as we as providers feel more pressure to see more patients in less time, I think that's something that all of us can recognize. Care then there's a risk that care becomes centered, not on the needs of the person, but around the needs of the system to get through the list, to get through the day, to be able to move through. So it's really important that we take opportunities like this to just keep reminding ourselves, just to keep grounding ourselves in the importance of person-centered care and what we, each of us as individuals, can do to contribute to that. So this is a busy slide, and many of you will be very familiar with this slide around self-actualization. And the purpose for showing you this slide is I want to just remind us that how people evaluate the freedom they have to decide how to live their lives should reflect the opportunities they perceive themselves to have, as well as the amount of choice they experience. So there's the opportunity freedom and there's a freedom of choice. And people's ability to transform that opportunity into reality is not just about them and how they do that, but also about how we, in terms of the society and the societal conditions that support it to happen. And I think advanced care planning is one of those situations where you're looking at the individual, but you're also looking at the importance of the conditions that enable it to happen. So this is the structure of how I plan to have this talk this evening. We're going to spend a little bit of time thinking about the what and why of advanced care planning. I've got how and so what, that will be threaded through the lecture. I will also then talk a little bit about the universal principles for advanced care planning, which is England specific, but I hope that it will have much commonality for people in the audience across the world. We'll talk a little bit about the NICE guidance and what it says about motor neuron disease and advanced care planning. And then we'll look very specifically at some of the evidence around advanced care planning in the context of motor neuron disease and a few take-home messages at the end. I am conscious that I'm probably talking, as we saw with that, some people have lots of experience already, and therefore I hope that this will resonate with your experience, but perhaps we'll come to that in the Q&A. Part of this lecture is also about looking at the emerging evidence, and so I will thread that through the talk as we go along. So let's start with a definition, and this is a definition of advanced care planning. This was one that was commissioned by the European Association for Palliative Care and was based on a Delphi consensus. There were 8 countries involved, all European, but most of them European, but also Canada and US. And this is the definition. I'll just give you a minute to read that for yourselves. Okay, now, however, I say a definition because that is not the only definition, because around the same time, there was another Delphi consensus attempt to define advanced care planning, which involved 52 clinicians, was very much North America, US, Canada, and a small percentage from Netherlands and Australia. And then later on, there was an attempt in Japan to look at a definition of advanced care planning that kind of fitted much more with the culture there, which talks about repeatedly discussing future medical care with family and or other closely related people and their healthcare teams. And the focus there was much more on the patient's dignity at the end of life. So the important thing, sorry, I'm just moving me to the next slide. Can I have the next slide, please? It seems to have got stuck. Thank you. So the important thing, I think, in definitions is just to think about what are the common threads. It doesn't really matter that those definitions are slightly different. The important threads are that it's voluntary, that it is with people who have capacity to have those conversations, that it is about the process, not just the outputs, but it's the process. And too often, certainly in this country, we have become focused on very specific decisions around do not attempt cardiopulmonary resuscitation and preferred place of death. Actually, it's much broader than that. It should be patient focused on what matters most to them, and it may involve others. So those are the common threads, I think, in those definitions. There's variation in emphasis, of course, around the actual decisions. So some of the definitions, particularly the North American one, is much more focused on specific treatments. There's the scope might be different around the age and so on, but also a slightly different emphasis between individual autonomy versus relational aspects and the involvement of family in that. And some differences in emphasis on focusing on choice and control versus dignity at the end of life. So those are all things that are important in thinking about the definition. Moving on to the terminology. I just wanted to sort of draw attention to a couple of these. So the term personalised care and support planning is one that is used very much by NHS England. To me, that is a big umbrella term that does include advanced care planning, but it's not exclusive to advanced care planning. So it's about all of care and support planning that is person-centred. In advanced care planning itself, there are some outputs that we are particularly familiar with around advanced statement of wishes and preferences. Another output might be about advanced decision to refuse treatment. And depending on what literature you look at, what country, other terms may be used like advanced directive or living wills. And then in this country, we talk about nomination of lasting power of attorney. Elsewhere, you might hear the term surrogate decision maker or healthcare proxies. And then there are other forms of planning for the future, which are slightly different again. Those that are focused on emergency care and treatment escalation planning, which may be very specific to a very certain context. So for example, people who may have convulsions, what happens when somebody has convulsions, the treatment escalation that's involved there. There may be treatment escalation around infections as well. And the term future care planning. Now, there are different definitions and terms used in our devolved nations. So, for example, in Scotland, the term anticipatory care planning is used rather than advanced care planning. And in Wales, the term future care planning is becoming the term to use rather than advanced care planning. But let's not get distracted by terminology, because you could go on arguing about what's the right term and so on. I think more importantly, let's move on to thinking about why. So why is advanced care planning important? Well, when advanced care planning is done well, people do feel they've had the opportunity to plan for their future care. They'll feel more confident that their care and treatment will be focused on what matters most to them, if at a future point they're unable to participate in decision making. And that's a really important part of advanced care planning, of course, is that it's actually about the future. Right now, if I change my mind, that's absolutely fine. But this can give people a greater sense of control of their lives. But there are also some people who will argue, why not? So I think it's right that we stop and look at those arguments. So there have been publications about arguing against advanced care planning. And those are the arguments. The arguments are that most approaches to advanced care planning encourage all adults to participate in the process, regardless of their health status. And that brings me back to the first point I made about advanced care planning being done out of or being expected to be done out of context, or that everybody is expected to do. And of course, that is not what proper advanced care planning is about. It is true that there is the evidence demonstrating that advanced care planning improves end-of-life care is really quite hard to get hold of. It's really quite hard to demonstrate, but we'll be looking at evidence as we go along. And it's not so straightforward, is it? It's not a yes-no question, as we know about evidence. The inability, another argument from them is the inability of advanced care planning to achieve the desired outcomes, because there's a gap between a hypothetical scenario and decision-making in clinical practice. And I think that's probably one of the most difficult things about advanced care planning, that we are expecting people to do, is to imagine what it would be like in the future. And that is a tough thing, and we will come back to that later on as well. And then their other argument is about there is a potential for unintended consequences. So by focusing on advanced care planning, we might detract from other things around high quality conversations and the training around that. I don't buy that one, because I think that high quality conversations is high quality conversations. The content might be different, but actually the training around high quality conversations is important regardless. So they're not two completely separate things. So let's start looking at some of the evidence there. First of all, this is a systematic review that Florin et al. Carried out. They wanted to look at the underlying goals of advanced care planning. And their argument was that if not everybody who's participating in advanced care planning are aware of the goals, they don't share the same goals, or if they don't endorse those goals, then they might hesitate to invest their time in and energy in advanced care planning. So it's really important to look at what the goals are of advanced care planning. They did a systematic literature search, and they screened over 4,000 articles, and then they did a documentary analysis on all of those and coded them. And what they looked at were the goals and the objectives, okay? And they found basically five sets of goals, really. There were the literature, or the research that looked at the goal being around respecting individual patient autonomy, being a very strong theme in terms of goals. So that might be one of the five goals of advanced care planning, and where healthcare decisions are based upon patient preferences and so on. But there is a possibility, of course, that therefore the autonomy that's expressed at the time of doing advanced care planning then becomes higher valued than the current interests of the patient. We'll come to that in a sec. A second set of goals might be around improving quality of care. And this is a way of tailoring care to the patient's needs. And shared decision-making here is obviously the critical point here. But in terms of these sort of discussions, when the goal is about improving quality of care, that very often healthcare professionals might then determine what are the subjects to discuss, when and what options there are. The third one is around a goal being around strengthening relationships. And you can see that that demonstrates a commitment by healthcare professionals and by families to and towards the patient in wanting to strengthen the relationship, in wanting to understand what's important to the person, and so on. A fourth goal is around preparing for end of life, and this is a much broader and more holistic concept than simply about treatment decisions. So this is about coming to terms with the end of life, finding meaning and finding peace of mind. And then, of course, the fifth goal is quite different to that, because that's about reducing overtreatment and what it means in terms of value at the end of life. So those were kind of five set of goals that they found. They also found in the literature the risks associated with each of those five. So with the first one about respecting patient autonomy, they found that the risk is that it suggests more control than is really possible. So back to what I was saying earlier on, where you're imagining and thinking hypothetically about what might happen. And those are all to guide decisions, but actually you can't necessarily control it fully, because things might not happen exactly the way you predict. If the goal is about improving quality of care, a risk is that it may become a moral imperative for patients. So patients are expected to do this so that healthcare professionals can improve their quality of care. Another risk associated with strengthening relationships is that maybe it might serve the needs of family members more than the patient's needs and their individual patient autonomy. A risk around preparing for end of life is advanced care planning being regarded as the panacea and it's sufficient and that's all that's needed. That as long as we're discussing advanced care planning, that's all that's important. And obviously that is a risk that we wouldn't want to take on. And finally, reducing overtreatment, which is probably the most obvious one, is that it risks limiting treatments for certain patients or groups. So that systematic review kind of really examined the underlying goals right across all those publications. But what about barriers to advanced care planning? So this is a piece of work that Rygens has looked at, and this was somebody who also led on that consensus definition that I showed you earlier on. They looked at the barriers looking at patient factors, so very much around uncertainty, insufficient knowledge, but also an expectation that perhaps doctors, and I think in this case probably other healthcare professionals, initiate advanced care planning. There are then the professional factors, which kind of almost mirror that. So a hesitance by professionals to raise this, not quite knowing when the right moment is, being fearful of taking away hope, and then the time constraint, which then leads us into the system factors, which kind of focus much more on the treatment and care and not having a kind of a coordinated approach to advanced care planning and being unclear whose responsibility it is to initiate that. So a number of barriers at different levels to advanced care planning as they found in their systematic review. Now I'm going to turn our attention away from direct advanced care planning for a second, just to draw on thinking a bit about behavioral approaches, because if we're encouraging people to undertake and to participate in advanced care planning, understanding a little bit about behavioral approaches might be helpful. So this looks a bit at the individual biases in decision making and this power of changing defaults of opting in versus opting out strategy. So this is about inertia. So going against a default option requires effort. There's a preference for us, in all of us, for having our rewards in the immediate future rather than a distant one. So trying to project ourselves into the future might be rather more difficult and sort of slightly counterintuitive than dealing with the here and now. There is the loss aversion and risk aversion. So our reluctance to take risk and accept potential losses unless this can be compensated by potential important rewards. What this means is healthcare professionals need to be able to explain the benefits and gains and contrast it with the losses so that these can be tangibly assessed. And if we think about motor neuron disease, which we'll come back to later on, but one in particular is around thinking about gastrostomies and having to think about that decision earlier on, because later on the ability to have a gastrostomy might get compromised if respiratory function is compromised. So that's one of those where actually you're trying to encourage people to think about something that isn't yet happening. And then framing. And I will talk to you about a study around framing in a second as well. But the way choices and options are presented to individuals affect the way they make decisions. And if you have too many options, it's very confusing. If you have too little options, it feels constraining. So this is where I call it the Goldilocks kind of effect, really. You don't want too many options. You don't want too few options. You want it just right and to be framed in a way that is understandable. And then the behavioral approaches kind of world, of which I'm not an expert, talks about the role of social environment in decision making, how we're likely to change, more likely to change our behavior if we feel we owe somebody something, and also that we tend to base our behaviors on what we perceive others are doing. In other words, the social norms. Now, previous research has shown that patients' choice have been affected by how messages are framed. So there was a study that looked at surgery for lung cancer and how when the treatment possibility was framed in terms of life expectancy, i.e. a positive framing, versus the probability of dying in terms of negative framing, that surgery was more attractive if you use positive framing. Equally, if negative framing is more sticky, so it's harder for individuals to switch from thinking about something that has been framed negatively to something that has been framed more positively. This was a study that Spivey et al. Did, where they actually basically it was an online survey. It was a national sample of individuals stratified by age, so they weren't necessarily people with any specific disease or conditions. And they were asked, had they already done, and did they already have an advance directive? This was done in the States. If not, then they continued down, and they were showed 3 videos, and the order was randomly assigned. So they might be showed a positive framing first, a negative framing next, a social norm next, or the other way around. So the order in which they saw those 3 types of videos were randomly assigned. And then they had questions after each video, including a comparison with the video previously seen, if you see what I mean. So that was the kind of framing they were trying to test out, what the effect of framing might be. In the negative framing, so negative framing appeared to be most effective in encouraging information. So people looked for information as a result of the negative framing. They didn't necessarily take action on advanced directives, but they look for information about it. Whereas those that were most affected by the positive framing seemed to be more effective in encouraging action, but not necessarily looking for more information. They were also asked questions about, was it convincing or not? With older participants, the positive messaging seemed to be more convincing. With younger participants, the negative messaging seemed to be more convincing. Make of that what you will. But I now want to move on to think about diversity, because of course, I've talked very much about advanced care planning as though it was a homogenous thing. But I have also referred to the fact that East-West culture might be slightly different, but of course, within each of our own societies, there is diversity. There are different people, different cultures, different languages, and this will affect advanced care planning and what we do about it. So there's a systematic review, which was mixed methods. They examined 35 papers. They summarized and tabulated the quantitative data and the qualitative data. They then carried out a narrative analysis. Now, in the primary outcome measure, there were 15 papers examined. All of them were from the United States, except one, which was from Kenya. And in those, they found that 12 of those 15 papers showed that white patients had statistically higher rates of formally documented advanced care planning in their care records than patients from other ethnic groups. But there was no significant difference in the presence of informal advanced care planning between ethnic groups. The secondary outcome measure papers were a bit more widespread. They were from the States, but they were also from Asia, New Zealand, and one from the UK. And those papers looked at the patient-based factors that affected advanced care planning and clinician-based factors affecting advanced care planning. And you can see them there for yourself. Don't think they would be of a particular surprise. But those around the clinician confidence around cultural values and ideals are important, because inevitably if we're involved in advanced care planning conversations, in initiating that, in supporting and facilitating that, then our own biases and the positions we're coming from is really very important. So the next study I wanted to show you was actually, again, a mixed method study also carried out in the States, where they basically talked to doctors who had come to the end of their clinical training, so just before they graduated. And these were doctors who were looking after, in all sorts of specialties, looking after people with diverse, seriously ill patients, over 1,000 of them. They were asked about barriers in conducting effective end-of-life conversations, including those who belong to a different ethnic or racial group. And they were asked about their top barriers to these conversations. And one of those 3 questions in particular that they were asked was about the ones about conversations with people who belong to an ethnic or racial group different from your own. And as you can see, this comes through again in those barriers. And the one I guess I want to pick out particularly is around the doctor's ignorance of patients' cultural beliefs, values, and practices. And although this study is about doctors, I think we can probably all say this is about potentially about all clinicians and all of us who are involved with other people where we're trying to facilitate conversations. So worth bearing in mind, how does it affect us? How are we affecting the conversation, whether that's consciously or unconsciously? This is an example of an intervention, again in the States, in New York, where they used a multi-level intervention to increase patient participation in advanced care planning. And they were particularly interested in thinking about the racial and ethnic diversity mix. As you can see, the two bottom last bullet point shows you they looked at the intervention was over a 2-year period. They looked at about 40,000 patients in the 2 years before the start of the intervention and the 2 years from the start of the intervention. And most of their patients were not white. There were 80 languages spoken amongst those patients, a third of whom did not prefer English language. So it was a very, very diverse group there. It was a multi-level intervention, so there are interventions at community, organization, provider, and patient level, and I'll tell you a bit more in a sec. Their primary outcome measure was indicated by the completion of an advanced care planning form. However, the advanced care planning form was either a living will or a healthcare proxy or a medical orders for life-sustaining treatment or a DNR, do not resuscitate or do not intubate orders. So those are the four. So as you can see, they're very, very medical intervention specific kind of focus on it. At the community level, the intervention they had was called My Life, My Way, and it was based on the Conversation Project, which is a public campaign for promoting end-of-life discussions between patients, family members, and professionals. They produced 2 educational brochures, one a conversation guide for patients, and details of those various forms. They produced a 5-minute animated video, which was created and uploaded to the hospital website, and they were very careful to avoid culturally specific references and medical legal terminology. And they made translation services available on request. So that was at community level. At organizational level, this was championed by the chair of family medicine. The leadership of the organization were basically told about the critical importance of advanced care planning, and there was a hospital-wide quality improvement program that was launched. And then at what they call provider level, which is really at ground rounds in the department, if you like, this was mandatory training extended to support staff. They appointed ambassadors, they provided conversation guides, and they included specific strategies for approaching patients from certain racial, ethnic, and cultural backgrounds. And the providers were invited to consider their personal characteristics and how this would impact on their ability to establish rapport with patients. And then at patient level, every patient over the age of 55 were targeted, asked if they already had one of these advanced care planning forms completed, and that was uploaded if they had, and if not, they were shown that same video to introduce the topic and then asked if they would be interested in meeting with a provider. So what did they find? They found that in pre-intervention, so both periods of time had a similar number of patients. They went from less than 1% recorded a living will or advanced directive to 60%. And they increased the number of healthcare proxies. The others increased, but not quite to the same extent, but certainly the advanced directive increased. They emphasized that the key lessons were about the importance of senior leadership, the importance of this multi-level intervention, and particularly about cultural sensitivity and the importance around health literacy. So I think what I'm trying to say there is think about the diversity, think about the situations in which we work, and what can we do to encourage and enable that to happen. Let me move on then to think about what are the universal principles for advanced care planning and how did they come about. So this was published in 2022 led by NHS England, but as you can see, lots and lots of partners involved. It was actually quite a brief publication because we were very clear that we didn't want a lengthy tome about advanced care planning, given the amount of resources that were already available in this. We also produce an easy read version. The actual Universal Principles document itself is 12 pages, excluding the foreword and the appendix, but that was pretty good for a national document. I think you will agree. So what was the background to this? So the Care Quality Commission, which is our healthcare regulator in England, produced a report called Protect, Connect, Respect, which was actually a response to concerns during the COVID pandemic about whether or not people were having decisions and advanced care planning and DNA CPR decision making forced upon them. So I won't go into any more about that report, but they came up with 3 sets of recommendations, and the Universal Principles were published in response to the second set of recommendation, which was about the need for a consistent national approach to advanced care planning. When we were challenged with coming up with a consistent national approach, it was well, what do we do? There is already so much training, so much resources about it. It really was not useful to write more stuff about it. But what we thought was actually it would help patients, families, professionals, everybody who's involved, if we had a consistent set of principles, but a small set of principles. The scope was, so I'm just moving me on to the next slide. The scope was England only. We kept it to high-level principles. As I said, we weren't trying to duplicate any existing resources. And what we said was these principles would be applicable to everybody, but then detail might need adjustment to meet different needs in terms of age, condition, background, etc. And the expectation was that people who are working in groups that are working with these diverse groups take responsibility for making those adjustments and making those available. So it sets that consistent national approach, but the next steps were up to everybody else. And this was just in brief the process where we started off with a task and finish group that came up with a rapid sort of a rapid testing, and then we went to a wider stakeholder, and it was signed off by the Ministerial Oversight Group back in 2022. And these were the principles, which will be no surprise, I think, to anybody here, that the 6 principles for advanced care planning should be focused around the person being central to the process, including deciding who else to involve. That was up to them. The personalized conversations about future care needs to be focused on what matters to them. And here, things like translation, interpreter services, having a trusted advocate, things like Braille, and all sorts of things that would enable people to have those personalized conversations were critical to doing this. That the outcomes of those conversations were agreed through a shared decision-making process, through a partnership process, and that these were documented in a way that was shareable. And then, importantly, that there was an opportunity and encouragement to review and revise the plan. And our office for the freedom to speak up was really important, was really keen that we actually included something very explicit about if these universal principles are not being followed, then anybody could speak up about it. So we made sure that this was happening at system level, at local level. So we then talked about, well, okay, those are the 6 principles, but there's certain requisites, isn't there, that makes it possible to achieve good practice. And these were the requisites that we came up with. One was that there needed to be public and professional awareness about what good practice in advanced care planning was like, what those principles were. There needed to be clear information that was accessible and that was in the right languages, in the right formats, that people could understand what it was about. That there was proactive identification of people who were likely to need to benefit from advanced care planning. So people who were perhaps likely to be in their last year of life, people whose condition was likely to deteriorate, even if it's not quite in that time frame. The importance of education and training, particularly in how to initiate and hold advanced care planning conversations, and in the Mental Capacity Act. Record keeping and information sharing was obviously critical, because no point having those conversations, documenting things, and then it being stuck in one place and people having to repeat themselves over and over again. And then importantly, the culture at organizational level that supports professionals to have those conversations, that gives time and capacity and training to enable that to happen, but also a system culture, or if you like, a societal culture that takes collective responsibility for supporting that. So back to what I was saying to you earlier on about self-actualization, the importance of the society factors that enables this to happen and supports this to happen. This is just about the partner organizations. As you can see, the Motor Neuron Disease Association was part of that document as well. So what about NICE, and what does NICE say about all this? Well, first of all, as I'm sure this audience will be very familiar with, there is the NICE, I think my slide is stuck again. Can I have some help, please, for my next slide? Thank you. Thank you. So these blocks, each of these blocks are the sections in the NICE guideline for motor neuron disease for the assessment and management. This was published in 2016 and updated again in 2019. But I've highlighted particularly the boxes where advanced care planning was specifically referred to. And as you can see, it was more than one box. It didn't just sit all in planning for end-of-life care. Right at the beginning, it talks about information and support. It talks about the importance of information and support being given by a neurologist with knowledge and expertise of how motor neuron disease may progress, and who has knowledge of advanced care planning, and that people are provided with opportunities for advanced care planning. In organization of care, MDT, multidisciplinary team access to specialist palliative care, again, there was reference to current or anticipated significant or complex needs and complex future planning. And then obviously a lot more around advanced care planning in the section around planning for end-of-life care. So you can see that even in the guideline that is about the whole condition, the concept of advanced care planning and future care planning is really very much embedded within the NICE guideline. Now, the important thing to remember is from the NICE guideline comes the quality standard, and I will talk about the quality standard shortly. The difference between the guideline and quality standard is the guidelines tend to be more comprehensive. The quality statement picks out a very few areas in which we should be driving improvements, and that's the area to focus on. I'll come back to that in a sec. But of course, NICE guidance isn't just about the guideline on motor neuron disease when it comes to advanced care planning. There's a whole lot of other guidance that also talks about advanced care planning. So the end-of-life care guidance, service delivery guidance for adults, talks about service providers developing policies to ensure that advanced care planning is offered to adults who are approaching the end of their life. So although that's not MND specific, it applies to everybody in that situation. And that policies should take into account underserved and vulnerable groups. And then the decision-making and mental capacity quality standard itself, the second quality statement says people aged 16 and over at risk of losing capacity to make decisions are given the opportunity to discuss advanced care planning at each health and social care review. There are also disease and context-specific guidelines and quality standards around dementia, around learning disability, multiple sclerosis, children and young people, all of whom talk about advanced care planning. And there is a quick guide for registered managers of care homes and home care services supporting advanced care planning. Now, this is not comprehensive. I have not listed every NICE guidance that has reference to advanced care planning, but what I'm trying to demonstrate there is it permeates a lot of the guidance. So it's really important that we don't think of it as a silo. It is actually part and parcel of what we do. NICE guidance also had a particular one around shared decision making, because advanced care planning, shared decision making is a critical and fundamental part of advanced care planning. And the guidance talks about having to embed shared decision making at organizational levels. It talks about things you would expect: leadership, culture, training, and so on. It talks very much around what needs to happen before those discussions take place in terms of offering resources, arranging additional support for people who might need that, during those conversations. And then during those discussions, agreeing an agenda, explaining what the aim is, communicating risk, benefits, and consequences, being able to chunk the information, check back that the person understands, and also after the discussions in terms of offering resources, additional support, additional meetings, and so on. Shared decision making, of course, is about here and now as well as about the future. But the reason I've added it here is because it's really important that the principles of shared decision making are embedded in everything that we do and think about. So that's all very well, but so what? What about the outcomes and impact of advanced care planning? So the Sudore, who's the group that did the alternative definition that I talked about, that was particularly in North America, they developed, again based on a Delphi panel of those same people, an outcomes framework for advanced care planning. You can see just very broadly that there's quite a lot of it that's focused around surrogate decision making. So 2, 3, and 4 are around surrogacy, but there's also outcomes that are focused around values and care preferences, and both the discussion of them and the documentation of them. Then what about the evidence around the outcomes of advanced care planning interventions? What's happened? So Brinkman did a systematic review where they looked at studies. 95% of them were observational studies, 80% of them were from America. And they were performed in hospitals or nursing homes. And as you can see, it's very much also focused around treatment decisions. Advanced care planning, they found, decreased life-sustaining treatment, increased use of hospice and palliative care, and prevented hospitalization. They found that complex advanced care planning interventions seem to increase the compliance with patients' end-of-life wishes. Gleason et al. Looked at home health staff, in other words, care home staff. They looked at healthcare professionals working in the care home settings. They included 6 studies. 3 of them were before and after studies. Their cluster randomized controlled trial that they included failed to show a significant clinical impact. So these are really based around the qualitative study where there were champions appointed. What they found was that having the champions kind of program increase confidence and improve the consistency for advanced care planning, but that those who were not champions had a poorer understanding of the program, so that cascading learning wasn't consistently done. So I think that's an important lesson for us in terms of how do you drive something forward within your organization, but actually take everybody with you. And that's not easy. And then Malhotra did a systematic review just last year. They published a systematic review that wanted to look at the efficacy of advanced care planning interventions on caregiver outcomes. And by caregiver, they are talking about unpaid carers, so people who are involved in looking after their loved ones with motor neuron disease. And what they found was that there was a large and significant improvement in the congruence. So in other words, the matching of the end-of-life preferences between the caregivers and patients. But in the longitudinal studies that they had amongst those studies, that actually over time, that effect actually declined. But they did find some evidence that advanced care planning improved bereavement outcomes, improved satisfaction with care quality and communication. It did, in a couple of the RCTs, reduce the decisional conflict and improve the burden. But they didn't find consistent evidence of mental health outcomes for these carers. Now, when we start talking about outcomes and quality and how we measure them, it's trying to define a measure that is meaningful is difficult, because as I think you might have picked up that a lot of the evidence I've pointed out here, a lot of them have very much focused around, appointment of a healthcare proxy, a surrogate decision maker, or around decisions that are very much around medical treatments towards the end of life. The American Academy of Neurology has a set of quality measures for motor neuron disease, and one of their 11 actually focuses on end-of-life planning assistance and looking at the percentage of patients who are diagnosed with amyotrophic lateral sclerosis who were offered at least once annually assistance in planning for end of life. So they've very much incorporated advanced care planning into their quality measures. But coming back to NICE then, and I mentioned the NICE guidelines then translating and moving into quality standards. There were in 2016, after the MND guidelines were published, NICE published its quality standard with 5 statements. And I've grayed out the first 4 because they're not specifically relevant to today's conversation. But the 5th statement is an important one, which talks about adults with motor neuron disease are given the opportunity to discuss their preferences and concerns about end-of-life care at diagnosis and key stages of disease progression. So although it doesn't use the term advanced care planning, that's what it's about. It's about future care planning. So let's unpack that a little bit and see what that means. What it means is adults with motor neuron disease are asked if they would like to talk about any concerns they have about dying and what they would prefer to happen or not happen at the end of life. And those are the outcome measures that NICE have identified for their quality statement. Adults with motor neuron disease feeling that they have choice and control over their end-of-life care and that they receive end-of-life care that's informed by their wishes and preferences if they lose the ability to communicate. Now you can see that it is not possible to collect this data at national level, but it is possible to do this kind of examination at local level, and it is important that that happens so that we are clear that actually that advanced care planning has a meaningful impact. So I now want to move us on to thinking a bit about the advanced care planning in the context of motor neuron disease specifically. So much of what I've said up to now, although some of it applies to motor neuron disease, some of it has also been much more generic. So why is it important to think about it in terms of planning ahead, specifically for people living with motor neuron disease? It's an opportunity to discuss goals, priorities, wishes. It's an opportunity to have that broader discussion about what really matters to the person. But in motor neuron disease, we know that disease progression may lead to a cognitive impairment and therefore a loss of capacity to make decisions in the future. And it may lead to a loss of ability to communicate at some point. And so it is really important that those considerations are played into thinking about the timing of advanced care planning. And there are some specific interventions in MND that are important to plan for in advance and to think about. And I think hopefully this is an audience that I don't need to emphasize that to, the importance of thinking about these interventions early on, and the need to make sure that the person understands the balance between benefits and burdens, including considering what circumstances they may wish the intervention to be withdrawn later on. So these are not straightforward decisions. They are decisions that you have to make several leaps into the future, and that can be quite tough to have. So when can advanced care planning be introduced? Well, it could, some people would argue, as early as possible. Some people would argue at diagnosis. I think those are very individual points that people need to think about, and they will be very individual to the person. There may be trigger points. So trigger points like recurrent hospital admissions, decline in function, weight, or respiratory status. It may be triggered by the caregiver feeling the need to be able to have these conversations, or their distress triggering those conversations. They may be about critical decisions needing to be made, but as we all know, that when critical decisions are needing to be made in a time-critical way, it's not the best condition to be able to have those conversations. So before that is best, but it's always difficult to know exactly when. And importantly, that there is opportunity to revisit and change. And remember, that was one of the 6 principles that we set out in the universal principles. Really important that people feel this is not set in stone. This is something I can revisit, I can change, I can keep up to date. Basically, it's about having a deeper understanding of the person's views, preferences, and priorities, and to facilitate that open and ongoing discussion. So it's not a one-off discussion, and that is really, really important. Now, for the next little while, I'm going to turn to some of the evidence around all of this. So first of all, looking at communication about end of life. And this is a scoping review which looked at those research questions. What's the scope and nature of published research on MND and health communication about end of life, and what recommendations might be able to be made? And they looked at, they managed to extract data from 211 articles. Most review articles refer to end-of-life communication really as a peripheral focus of investigation rather than being the central point. And few articles discuss communication about specific end-of-life options. But nevertheless, they found the themes that were identified were around communication barriers, so insufficient information being given, lack of options being communicated. There were about communication facilitators, so healthcare professionals perceived to be friendly or kind, sufficient information being given about the disease and or assistive devices. Another theme they found was difficult conversations, end-of-life discussion avoidance, or timing for difficult conversations. So these were some of the literature around this area. And then about delivering the diagnosis itself, the methods for delivering diagnosis, also publications around badly communicated diagnosis. And then the last theme that they found was around functional communication challenges, the severity of communication impairment, and the strategies to address speech loss, including assistive devices. So communication recommendations draw attention to the communication processes. So that was their second research question. And you won't be surprised that they found that although it drew attention to communication processes, style, and content, there really wasn't systematic guidance for clinical practice. So their recommendations were all about improving those practices, improving the content, improving the style. And also suggested that there should be some kind of standards needed around facilitating shared decision-making, perhaps the use of decision-making aids, and I'll be interested to hear your experience of decision-making aids, and improving patient-carer relationship. So that was about the communication itself. What about patterns? And again, this was another piece of work that looked at scoping review that looked at the specific questions about how do people communicate about life-sustaining and life-shortening options, and what are the challenges for everybody involved in decision-making communication about these topics. They found these 6 patterns, which are different, but sometimes also opposite communication patterns. So they found patterns around communication being avoided or delayed, but also about those that actually were talking about dying, were thinking about it, and were seeking assistance. So those are all the 6 communication patterns that were found, and particularly the last 2 being very contradictory, those that were engaging in advanced care planning, but those who were avoiding or delaying advanced care planning. Then there was a realist review, which looked at multiple sclerosis. So this is not MND specifically, but I think quite a lot of it perhaps has relevance to MND as well. By realist review, what they were doing was looking at trying to develop a theory on engagement with advanced care planning for people with multiple sclerosis. How and why do they do that? What makes it happen? What's the context in which this will happen? And what are the mechanisms? So what they found was that the cumulative losses over time led to acceptance of multiple sclerosis as a progressive condition, and then advanced care planning became more relevant. That the trusting and empathic relationships enable empowerment. I think that probably applies whatever the condition is, and not just to MS. The fear of being a burden to family motivates engagement in advanced care planning. And advanced care planning as a tool for enabling control and autonomy in decision making, I think is self-explanatory. Skilled communication and previous experiencing of witnessing death perhaps sometimes facilitates, sometimes hinders engagement in advanced care planning. We then move on to looking at the, sorry, I'm just going to find my clicker again. Then we move on to looking at a scoping review that looks at neurodegenerative disorders. 2/3 of the studies they looked at were people with dementia, but 13% of the studies they looked at were specific to MND. And as you can see, and I'm not going to spend time on this slide, but as you can see, there's a whole variety of interventions that they found were relevant in this subset. But overall, that advanced care planning was influenced by difficulties to predict time and features of disease evolution, and that the timing to initiate advanced care planning may be different between the different neurodegenerative disorders that they looked at. And a common barrier is the patient's cognitive capacity. So introducing this early is really very, very important. And as you can see, debate over which outcomes are most suitable continues. But what about MND specifically? This was a systematic review carried out by Murray. It involved just 16 studies, 12 of them were quantitative and 4 of them were qualitative. And they looked at the prevalence, first of all. The prevalence varied across the studies from 15% to 90% of some form of advanced directive or advanced care planning. The higher rates tended to be in the States, where federal funding required patients being asked about advanced directive. The rates of completion increased with disease progression. It seemed to be a strong catalyst for advanced directive completion. That personal health goals and clinical circumstances were likely to influence decision making, but the optimal timing were unclear. And actually, most of the studies really looked at when they happened rather than what the ideal timing should be. And this whole idea of symptom progression versus earlier discussion and what should we be doing. It also found positive outcomes, but also some negative outcomes. And importantly, that the efficacy of advanced care planning may be compromised by our own lack of awareness, personal professional beliefs, and or reluctance to discuss deaths. So that's all very well looking at what the literature says from the point of view of interventions in that way. What I want to look at now is actually the patient perspectives on the goals of care conversations. And the study I'm going to share with you now is actually not a very big study, but I think it's important because it sheds some maybe provocation for us thinking about these conversations. This is a survey on patient perspectives on goals of care conversations, and it was done looking at people who attended the motor neuron disease MDT clinic. So this was routine attendance. There were 49 surveys, 45 were returned by patients, 4 by caregivers, with the patient present and providing the responses. And the median duration for which patients reported experiencing symptoms was just over 2 years, and the median months since they had a diagnosis was about 8.5 months. And these were the findings of the survey, that actually a lot of patients started thinking about future medical treatments 1 month after diagnosis. That 71% of them had discussions about future medical treatment they would want when they became seriously ill, that they had these discussions with their spouse, with another family member, with doctors, and with lawyers. See, these are patient-reported, directly patient-reported. When they were asked who initiated the conversation, 77% of them said they did. And then sometimes it was either their spouse or significant others or another family member. There was no significant correlation between the timing of the diagnosis and whether the discussion had occurred. And 47 respondents reported that they had discussed invasive treatment with others. Okay. Now, what about the comfort level of those conversations? This is a busy slide, but I've highlighted. Oh, can I have the next slide, please? So I've highlighted, this is a busy slide, but just look at the bits I've highlighted, because the first row, the first set of figures are about the comfort level in discussing treatment choices. And as you can see, a lot of these are skewed towards people being comfortable or very comfortable discussing treatment choices. And treatment choices there were cardiopulmonary resuscitation, ventilator, feeding tubes, etc. And the second set that I've highlighted there is about comfort level in discussing with others and who they were comfortable discussing these decisions with. Okay. So actually the comfort level, to me, what's striking is the comfort level is perhaps considerably higher than healthcare professionals who are reluctant to initiate conversations would assume. And that's an important thing for us to bear in mind. But equally important to bear in mind, of course, that not everybody is comfortable or very comfortable. You have people at the other end as well. But perhaps this whole idea of this elephant in the room is an important thing for us to bear in mind, that actually it's there, it's in people's minds, and the fact that we won't acknowledge it may make it difficult for people to open up those conversations. Remember back earlier, I talked about one of the barriers being people waiting for healthcare professionals to initiate the conversation. And then this is also part of the study that looks at the importance of the decision-making factors when they're thinking, when they're considering treatment interventions. And the three that I've highlighted are where more than 60% think it's either a lot or great deal of that decision-making factor. So dependence, as you can see, is a very high level of people that look at dependence, look at what's best for family, and look at potential to improve as being the things that influence their decision. Right. So as I said, that was a small study, but I think it has some really interesting provocation for us to think about in our own practice. This next one is actually, again, a very small study, but it is a qualitative study that looked at information needs. So this is actually asking people, when they're looking for information on the web, what sort of search terms do they use? What content and what information would they consider to be important on a website for advanced care planning? Because remember, we said that if you're going to have advanced care planning conversations, people do need information to be able to help them think about it. And most interviewees considered that it was important to be encouraged by the information to think about it. This next slide I'm going to show you, you really do not read the detail of it, but I just wanted to show you the busyness of the search words. That these were the search terms that were used. Remember, these were only 9 people interviewed. These were the search terms they used in order to try and get information for themselves. And the themes that came out were around the kind of information needs were around disease trajectory and the quality of life. What kind of medical treatment decisions, what information they needed in order to make decisions about medical treatments, including cardiopulmonary resuscitation and non-treatment. Practical support in arranging care. Guidance in advanced care planning. How to communicate treatment and care preferences in a way that's effective. They were looking for peer support and ability to share experiences. And relatives were looking for information as well. So I've shared with you quite a lot of the evidence around advanced care planning, around motor neuron disease, looking at the NICE guidance, looking at the universal principles. In the last few minutes of this lecture, I just want to perhaps share some take-home messages. And these are very much my personal thoughts around take-home messages. So again, in our Q&A, you may have other views that you want to share as well from your own experience. My first take-home message is about the importance of this advanced care planning process being voluntary and being patient-centered. That there is a balance that we have to strike constantly between keeping that offer open, a gentle challenge, but not forcing this on anybody. Remember, this is a lot of this, and a lot of the reason that we talk about the why of advanced care planning is about giving people that sense of choice and control, that sense of autonomy. But with that also comes our duty to do no harm. And so it's really important that we keep in mind all the time that people are at different, different stages of being prepared and ready to have this conversation. And it really must be voluntary. So therefore, we must be careful that our systems do not impose a requirement for advanced care planning as a kind of tick box that needs to happen. Really, really important that we do that. We need also to be aware of our own bias, though, and perhaps our own hesitation and nervousness about initiating conversations, And the risk, therefore, that we increase that inequity. So maybe we find it easier to have these conversations with people who share our language, who share our culture, who share our values. It's easier to open up a conversation. But then what about people who don't share that, but who have just as much right to have those conversations, to have those opportunities? So being really conscious, and that's where I think that self-awareness and that self-challenge becomes really important. So that sensitivity about cultural perspectives and norms, recognizing that for some people, it is also about not so much about them and their own personal autonomy, but the views of the whole family, the relationships within that, their significant others. That's really important for us to bear in mind. So it must always be voluntary and patient-centered. There's a term that we use. I am a qualified coach, and in coaching we use the term in service of the person or in service of the coachee as we use. So we must, and I think this is really relevant for advanced care planning, that it must always be in service of the person. So we must never force these conversations because it suits us, because it suits our organization, because it ticks the boxes, because it increases our outcomes as we measure it. What it must be is that it is in service of the person, that it is, the purpose of it is to ensure that they have the opportunity, if they wish to take it up, for that patient-centered conversation, potentially leading to decision-making, but it doesn't always have to lead to decision-making in the first instance. It is about process. My second take-home message is about pacing. Pacing is important because this planning ahead, future planning, there is a requirement. It needs emotional preparedness and it needs emotional readiness. And I've separated the two out because I think they are slightly different things. So being prepared emotionally is important, but just because you're prepared emotionally might not mean that you're ready at that particular setting. It just might be the wrong time. So having been both prepared and ready is important. There needs to be information preparedness, and some of this may be about having information beforehand, having the opportunity to think about it beforehand, and then having that recurrent opportunity. So pacing is very important. And I want to take this opportunity perhaps to recommend this planning ahead tool that is available on the Hospice UK website. The development of it has been led by Catherine Mannix, who many of you will know, will have heard about. It is still very much seen as a pilot, so they are still trying to develop it, still learning from it, so they still look for feedback from it rather than saying this is a definitive tool. I have found in my own practice that it's really useful to share that link with my patients when I'm encouraging them to think about advanced care planning, to think about planning ahead, and this is just a screenshot, because it just takes them through that thinking. And what a lot of my patients that I've recommended this to have found helpful is that it allows them to go away, have those conversations, dip in and out, talk to different members of the family as they wish, and then come back when they're ready in order to have a more formal conversation. So what's my third take-home message? And I would share it if I could. Thank you. Advanced care planning requires imagination. It requires courage and it requires energy. As far as courage and energy is concerned, we all know that there are moments when we feel more courageous and more energetic, and there are other times when we feel less. But importantly, the reason why I say it requires imagination is because you're asking people to think about a time in the future, to think about a time that is not completely predictable, that is actually quite hard to think about, and to think about what their decision might be at that time. So, you're asking people to do an awful lot of what ifs. So it does require imagination. And when you imagine how you feel at a future date, you're unaware of subtle but powerful biases that might frame the way you think. And so it's just I think it's just, there's nothing we can do about that. Advanced care planning is that. It is about the future. It is about thinking of a time when you might lose capacity, but it is about acknowledging that this is hard. This can be hard. And that we allow the space and the, I guess, the support to do that kind of thinking. So just bear that in mind. And particularly bear that in mind if you're particularly energetic about wanting everybody to do their advanced care plans. Just think, and just think about timing. And sometimes today's not right, tomorrow might be right. And sometimes tomorrow's still not right. So waiting for that time is important. But the important thing is people having the opportunity, that door being kept open. So what are some of the fundamentals? Think about the timing. Open that door, keep it open. And I've said, listen, listen, and listen. Really important. Obviously, we are sharing information, but it's the listening that's important. And that we listen with our ears and our eyes and our senses. We listen with our gut to what the person is saying, to what they're thinking. And to have the courage to ask for clarification if we're not sure. So not to make assumptions, but to ask those questions. To be honest about what we know about the future, to be able to share information honestly and not to try and fudge it. And a fundamental is about being able to step forward with the person, to step back, and to step sideways. So it really is very much a dance, if you like, with the person and with anybody they choose to involve. So some people will want to do this very individually. Others will want it to be part of people who are important to them being part of that whole process. That must be respected. Obviously, we need to document what's going on and to have that opportunity for further conversation. And I've often seen in good clinical notes where it might refer to the fact that the person does not want to talk about advanced care planning right now, but will be open to having that conversation later on. So those sort of documents are really helpful for your colleagues because we all work as part of a team. So just because somebody doesn't want to talk about advanced care planning with me today doesn't mean they don't want to talk about it with my colleague tomorrow, and that's absolutely fine. So make sure that we do that. Remembering that advanced care planning is like any medicine or any intervention. It has a great power to do good, but it also has side effects and burdens to be considered. And it really has to be individualized to the person and their whole context. And finally, genuine curiosity, I think, is the take-home message I want to leave with you. Genuine curiosity and interest. Capacity, I've already mentioned, is important, but the patient's voice matters even more. So although I've talked about advanced care planning, must be with somebody who has capacity. Even somebody who has limited capacity will still be able to convey what's important to them. It's still important that we capture those, even if it's not technically advanced care planning. So remember back to that phrase I said, always in service of the person. So that curiosity, that understanding, that really wanting to get to the bottom of what matters to this person, what makes it person-centered to this person, is the critical bit, I think, for us all. So thank you for that, and thank you for your time.
Well, wow, what a comprehensive and above all passionate and thoughtful presentation we've had this evening. Thank you so much, Professor Biwi. It's been really wonderful to sit here and hear those questions answered. We've got some more questions from the audience, but firstly, I just wanted to kind of highlight some of the really important messages. I've written down, I write as I think, and I've written down, you know, always person-centered, thinking about keeping the person. And you're right, that is so difficult. We're all so busy. And it's all very, very challenging when we, as you said right at the beginning, but so thank you for keeping us centered on the patient and the service user, but also the views of the carers and the family, and keeping that door open for those important conversations. They're really wonderful. And I'm really struck because I'm very interested in working with people who speak languages other than English. And I know it's been in the media just recently about services for babies and mothers, and how crucial it is to their care, to understand their care, to make informed decisions. So working in home language, working alongside interpreters, making sure that access, as a speech therapist, you would not surprise I'm picking on the communication aspects there. So really pleased to see those. Now we have some questions, but I'm just trying to see them because they're slightly cut off for me. Let me see if I can get them clearer. Okay, so the first, forgive me if I've cut off the beginning of your name, it's Lucy Hawking. What resources are available to support family carers so they can give the best possible care and support to a loved one who is engaged in advanced care planning?
Okay, I mean, I think there are lots of resources, probably in slightly different places. My thinking is that in the first instance, a lot of the voluntary sector bodies provide really good. So the MNDA website provides a lot of helpful resources. So in terms of resources, informational resources, I think there's a lot of web resources that's available for that. In terms of thinking about, as I mentioned, the planning ahead tool is a really useful one where actually family carers and the person they love, the person they're looking after, can actually almost have those conversations together because it provides a bit of an information prompt. I think there's also then the practical resources that support that, and that may be maybe in your area there may be individuals where or organizations where there are focus groups. Some of the death cafes may have some of these conversations as well. So there are places where these conversations can happen. But I think I would say start with the websites that provide good resources because they often signpost you to other resources that's available as well. I hope that answers the question, Lucy.
Thanks to Lucy from the Stephen Hawking Estate for that question. The next question is about data collection, and this is from Pam Enderby, Professor Pam Enderby from the University of Sheffield, who, as you know, is interested in outcomes, and data is incredibly helpful on a population level. So you mentioned that this is a real challenge at national level and is only done at local level. Could you talk a little bit more about that and why those, what are the barriers and what could we do
Sure.
to kind of overcome those?
Okay, I suppose I shouldn't say it cannot be done at national level. I think it's difficult to do it because if you are collecting, if you can translate, for example, those outcome measures that the NICE quality statement talks about, so translating that into some kind of a quantitative data, then it is possible for that to be aggregated and collected. But as you can see from a lot of the evidence I drew on, particularly from the States, a lot of those outcomes were very, personally, I would feel they're reduced to treatment decisions. And although, of course, that is an important part, it is not all. So I think my concern is really more about how do you get that breadth? How do you get the depth of, for me, the most important outcome in a sense is really, have we honored the person's wishes? Have we taken them into account? Now, that doesn't mean doing exactly, so it's not about matching what they've said with what we did, because sometimes circumstances change, it may not be possible. How do we demonstrate that we've actually taken what they've said as their preference seriously into account, done our best to try and honor that? How do we demonstrate that? And I think that is for me, is almost the holy grail of it, is how do we actually get that? That's the bit that I think is, I cannot see how it can be done at national level other than through research and so on. But in terms of routine monitoring, I don't think we can do that easily. We might be able to do that with things like advanced, is there an advanced directive? But does that, is there an advanced decision to refuse treatment? Is that meaningful? Just knowing whether there is or not feels to me a bit narrow. But I bow to people who are working with data, because I think that is the bit that's tricky.
Thank you. That's lovely. So Emma Townsley from UCLH has asked, what can we do when a patient or service user is only ready to discuss care planning at a critical time, and how do we address that?
I think firstly, we have to respect that. That maybe sit uncomfortably with us as health professionals. We can see all kinds of, scenarios where that's going to be very unideal and unoptimal, but actually we do have to respect that. But I think you have to step back and kind of say, have we made all the right efforts? Have we thought about what might be stopping this? And it may be possible, depending on your relationship with the person, to open a conversation about why they don't want to discuss it. I think that's okay to have that discussion. But sometimes people are just not ready because you are asking them to face something that is really difficult. And the timing of that has to be so important for that person. But I think just to sit back and kind of say, well, if they haven't, that's okay. That's not okay either. So it's getting that balance of saying, it's like any intervention, isn't it, in healthcare, that we are constantly thinking, is this right? Is this the right time? Have we got the balance between benefit and burden and side effects right? It's the same thing.
Thank you. I think this one's from Janice Hattrick from NHS Scotland. So Janice says, bearing in mind the sensitivity and complexity related to advanced care planning, could you please provide additional information or advice on how and when to review, particularly when someone's experiencing fast disease progression, and maintain that balance with doing no harm? So I suppose this is a progression of what we were just commenting on, really.
Sure. So, I mean, I think this depends on the setting and circumstances. But for example, the triggers, like somebody being admitted to hospital, that's often a trigger for asking them about whether what they said previously was still what they felt right now. So I think that's fine. I think that the clinics is probably a good place when they come back to MND clinic. And there was a study that I didn't really refer to where it was followed through, so that palliative care was part of that clinic. That clinic was kind of watching both their progression, but also raising the conversation every time. And actually what it demonstrated was the patients actually felt confident that there was going to be a conversation when there needed to be a conversation. So I think it is about doing that. So think about the context that you're in. Think about the triggers that might allow you to open that conversation, that feels right to open that conversation.
So as you were saying before, that open door in and of itself could be a comfort, and the person will then take that opportunity when they are ready.
Yeah, and I suppose continuing that sort of analogy, you open the door, you might have to just, move the door a little bit every time, because otherwise people might become unaware that that door is open, if you see what I mean. So you might have to just rattle it a bit to just remind them that it's there.
Super. I love a good analogy. That's super. So Sophie Cottrell from North Bristol NHS Trust says that she recently saw a documentary about Rob Burrow. There was a scene where he declined to discuss advanced care planning, but it seemed that his wife really wanted to. To what extent can we hold discussions, give information to carers and family if the patient themselves does not wish to have those at the time?
I think that we look after both the person and the caregiver, and therefore it's important that we are able to have those conversations. Now, I think it might be a different matter if the person says categorically, you must not have those conversations. The patient is our primary patient. I think most people might not want to be part of that conversation, but would be prepared for you to have that conversation if the person, their loved one, wanted to have that conversation, but they might not want to hear it, and they might not want to have anything to do with it. And so as healthcare professionals, I think we need to be able to find the opportunity for those conversations to take place separately, and to be able to have those discussions, because unless the caregiver, especially if they are the caregiver at home, is prepared, you're asking them to do something really tough with being unprepared. And understanding what's important to them is also important.
Yes, absolutely. That balance is very important, isn't it? Adele Tomlinson from the Royal Hospital for Neurodisability says, how do you approach advanced care planning in MND patients who have already had emergency interventions, such as long-term ventilation? For example, do you revisit the life-sustaining intervention that was made in their best interest, or focus on what they want in the future?
That's a really tough question, Adele. I think this is a reality, though, isn't it? Because although we talk about wanting to have advanced care planning conversations in order to avoid that kind of situation, it can happen. I think that it's, I guess it's both. So one is the intervention they have, and that would be true of any intervention that anybody's having at any time, not just about ventilation. Is this something they wish to continue? How is it affecting them? How do they feel about it, and so on? I guess if they are very, very ill, the energy and the capacity, and I don't just mean mental capacity, the capability, if you like, to have very thoughtful conversations about the future may be rather hard for somebody who is in that position. So again, I think it's about not insisting that there is an advanced care plan, as it were. It's actually about the quality of the conversations.
Thank you. Another one from Emma Townsley. The Malhotra review, which you mentioned in your presentation, seems to focus on carer experience. But was the experience of people facing end-of-life care improved? So I think some clarification on the findings of that study.
Yeah, I think that was very specifically looking at the impact on the caregiver experience. So that particular review was looking at that one. So they weren't looking, so their research question wasn't about the person's experience.
Thank you. Claire Scott from Leicestershire Partnership NHS Trust asks, does the high priority given by the healthcare system to identifying and managing risk result in a bias towards that negative framing that you discussed earlier?
I think there's a risk that it does, Claire. I think that the way we have those conversations still can be us working out what I suppose the right balance of framing, because as you can see that actually positive framing versus negative framing have got different effects. And actually what we're trying to do is that Goldilocks effect, isn't it? It's actually trying to get that balance for the person so that we're framing it as realistically as possible. So I think whilst we can draw lessons from negative framing and positive framing, I think what we've got to think about is how do we do this realistically and in a way that's understood? Because asking people to make really difficult decisions about the future, if we're trying to bias it one way or another, is really unfair and unethical. I think we've got to try and frame it as realistically and in an understandable way and in chunks, perhaps, because it's not a one-off conversation.
Super. One from me, really. I just wondered, looking to the future, there's lots of advances in technology and all sorts of things coming along. I mean, before the pandemic, we wouldn't have really thought about doing presentations online and having access. People did do it, but it seemed a bit eccentric. Now people take that for granted. So the world changes rather rapidly. What if I gave you a kind of looking glass, a crystal ball, what would you like to see in services that would really enhance the work that you do?
Do you mean in relation to advanced care planning, Sean,
Yes.
or broader than that? Right. Okay.
Well, I mean, it really open to you, but I was just kind of thinking, you kind of had some really good take-home messages. So what would the world look like if people were doing this correctly, and what would you like to see building further?
So I'm a bit of a dinosaur when it comes to technology. So as you can see from the times I've struggled to move my slide on. So I think for me, the ideal would be that balance again of being able to support, because actually I think there's a lot of information, and we saw from that small study of people looking for information, people search for information. So I think the first thing is making sure that as much of the information out there as possible, and it's out of our control, I know, is as accurate and as kind of realistic as possible. That's the first thing, really, is I would like to see that that information is available to people, that's reliable. And then I think it's a balance between giving them the opportunity to be able to access the information, have those conversations, dip in, dip out. Maybe even, if thinking about services, if you're providing a service, maybe the ability for people to be able to ask questions. So not actually not making it too heavy that this is the consultation in which they've got to make some advanced care planning decisions, but actually it's a conversation over time. And can we do that can we use technology to do that? Some of the people who are more well up on technology and in the audience might have better ideas on that one, but I'm thinking that's the kind of supported conversation, I guess, that technology might offer. But I don't think it takes away the human factor, because I don't think even AI, I'll say this, put it out there, I don't think even AI will be able to make that point that I made about listening with your eyes, ears, and senses. Maybe it will someday. I can't imagine that. I think it needs us. It needs a human-to-human interaction.
Yes, super. I'm glad you've said that. That's very reassuring for us. And don't worry about the technology. I think it's not a proper meeting unless there's been a next slide, please, comment at all. We have another question from Sadie Bailey. So if a patient does not have capacity to make an advanced decision, and there are different opinions on what they believe the patient would want from the carers and family, and repeatedly refuse to have a best interest meeting, what would your next steps be? So we're sort of talking about when there's disagreement across the family, carer and patient unit, if you like.
Yeah, I think these are very difficult situations that we can find ourselves in. But I think at the bottom line is we have to remember that the Mental Capacity Act sets out what we need to do. It is about having best interest. If the family will not get involved in a best interest decision meeting, then we've got to get on with it, because ultimately our responsibility is to the patient and to make the best interest decision that we can make for that person. If we can keep trying to take the family along with us, that's obviously important, because getting into a conflict situation is no help to anybody, and is a complete distraction anyway from looking after the person. But I think we have to keep in mind that the best interest of the patient is what we have to absolutely focus on.
Thank you. That's super. Well, I think it looks like we have reached the end of the questions from the audience. So it just remains for me really to thank you, Professor Biwi, for your, as I said earlier, it's been so interesting. It's just flown by for me. I'm sure it has for people who are watching as well. And I think your passion for this topic has really come across. It's really very central to a good dying experience, and I think it's been a really wonderful message to get across, and something that many people find difficult to discuss. Just to say to people that the presentation and talk will be available as a recorded webinar online. So if you would like to revisit any of the wonderful information or Q&A that we've just had, then you'll be able to access that quite soon. A reminder that there is a CPD certificate available to download via the PDF link at the bottom of the digital page. I'd like to thank the technical support for making it run so smoothly. That's been a real joy to do. And you might notice that you have a Slido toolbar participant, very short, we promise, very short evaluation, which helps us to ensure that we can meet the needs of people for these lectures. And finally, really just to say a big thank you to the Stephen Hawking Foundation for funding these talks, for the MND and RCSLT for hosting them, and we really hope that you take the learning from today and apply it in the real world so we can reach that vision that we discussed earlier. Thank you so much for joining us this evening for this wonderful talk. I'm sure you'll have had some really good take-home information to share with your colleagues. Thank you so much for joining us. Thank you once again, Professor, and good evening to everybody. Thank you.